So I'm a board certified psychiatrist, and it's my mission to help psych NPs learn and master psychiatry. So in this video, we're going to be covering how to taper Venlafaxine and Effexor. So this is one of the most notorious medications that patients struggle with getting off of. They experience withdrawal, brain zaps, nausea, vomiting, GI disturbance. And so if you've never helped a patient get off this medication, then I'm going to share with you exactly how you can do it. It's going to be one of the most difficult that you'll encounter in your career, so I think it's really important that you know and understand how to do it, so that way you can guide the patient with clarity. And so I want to share a story with you. So the last time that I tapered this medication was I had this patient who was on Effexor for OCD, and she had been trying it for 6 months or a year with a previous provider, but found it wasn't really working. And then she came over to my practice. And so what I did was I started tapering her off Effexor and then cross-titrated her to fluvoxamine, Luvox, because I wanted to use that to target OCD. And over the course of 6 to 8 months, we were able to slowly get her off the Effexor and get her on a therapeutic dose of Luvox, and that really helped out her OCD. So I'm going to share with you exactly how I did that and how I would go about tapering Effexor in general. So the first thing that we got to understand about Effexor is its dosage increments. So typically a standard therapeutic dose of Effexor is 225 milligrams. And so the way that I recommend providers try to taper off Effexor is to go in 37.5 milligrams at a time. So when we start from 225, then we go down to 187.5, then we go down to 150, then we go down to 112.5, then we go down to 75, then we go down to 37.5, and then ideally 0. So this is the standard therapeutic or tapering process. However, sometimes what I find is that it might be hard for patients to get down from the 37.5 to the 0 directly. So I might go to the 25 milligram in between. Or here, I might go to 50 milligrams in between, and I'll walk you through exactly how I do that. The hardest point of tapering is here and here. So here I'll write hardest. And the reason is because now the patient's already been on this dose for X amount of time. And so to start decreasing that, the body isn't used to it. And so the patient might experience some withdrawal side effects here. And then here it gets hard because now you see how we're going from 75 to 37. So this is now a 50% change. Whereas here, this is only it's like a 20% change or less than that. So because the change is smaller here, and especially here, but the change is bigger here, this is where people tend to have more of the side effects here and here. So when you start reaching this point over here, you might start doing what's called a hyperbolic taper. So I'll write H here and then H here. What does this mean? So a hyperbolic taper essentially means that as you start going down, you start decreasing the dosage changes or increasing the time changes that you make, because you're going at it hyperbolic. You're not going in a linear fashion. And the reason is because, again, the change from here to here is 50%, and then here, right, is 100%. So that's why we want to decrease the intervals that are happening here. So how quickly do we go about this taper? So the speed, so I'll write speed. The most important thing to remember with the taper is it depends on patient response. So basically, you could do a week here, you could do 2 weeks, you could do 4 weeks, you could do 2 months. And it depends on how the patient responds. So what I like to do is, okay, I'll do this, and then I have a rule of thumb depending on how long the patient's been on it. Because if the patient has been on it for longer, then it's more entrenched, it's more tightly bound, and it's harder for the patient to shift than if they've only been on it for less. So I have the way that I break it down. So less than 6 months, and then 6 to 24 months, and then greater than 24 months. So this is the criteria that I break it down in my head. So if it's been less than 6 months, I like to give the first step 7 days. If it's been 6 to 24 months, 14 days. And then if greater than 24 months, 28 days. And note, this is per step. So each step, so meaning this step, and then this step, and then this step, etc. So this isn't saying you do the whole taper in 7 days. So what this means is that, okay, the patient's taking 225. Let's say they've been on it for 5 months. And then I bring him down to 187 for 7 days, and then 187, then 150 for 7 days, and 112 for 7 days, etc. But the key is this is just a guideline. The most important thing is it depends on the patient's response. So for example, let's say I do the 7 days here, and I find that, oh, the patient is still experiencing side effects, like withdrawal side effects. Okay, then maybe I will go a little bit slower. Like I might say, hey, you know what? Let's make it 14 days. Or like, same thing here, here, here. But it could be the opposite as well. So for example, the patient could have been on it for 28 days. And then I say, okay, let's bring this down here. And, 2 weeks in, the patient's like, yeah, I feel fine. I'm ready to go to the next level. And then they go down to 150 and they're totally fine. That's why the patient response is the guidance that you want to use. This is just a guideline on, approximation, but ultimately how the patient responds will dictate the speed of your taper. So now I want to cover what we do in this area here. Like what does this refer to? Effexor comes in the 37.5 form, right? So 37.5 milligrams, so that's the XR. But there's also a 25 milligram IR. And so this 25 milligram IR can be used over here. So you see, this is how I get the 50 milligrams. So this is 2x25. And then here, right, so this is obviously 1x25. So this can be an in-between to go here. So now let's say that we are here, right? So this is notoriously where people will have the most difficulty. So what do we do at the end? At the end, we have a couple options that I like to utilize. So one, of course, is to go to 0, right? So go from 37.5 to 0, and that might work for some patients, which is totally fine. Another option that I like to do is, actually I'll write this here. So one is go to 0, 2, all right, is go to 25, so 25, and then 0. Number 3 is to space out the days, so Q2 days, Q3 days, etc. So what does this mean? So now, like let's say the patient's going from 37.5 to 0, and it's too much. So I might say, you know what? Why don't we space it out instead of every day to every 2 days? And now instead of every 2 days to every 3 days. Okay, and then now instead of every 3 days to every 4 days. So this way they're still on the 37.5, but they're decreasing the frequency of it. And that's one way to use the hyperbolic taper concept, is now we're still going down on our overall amount of medication, so Q4 day, etc. So those are 3 options that I've used. Another option, so number 4 I'll write here, is to do beads. And what this means is basically the Effexor, it's in a capsule. And so this capsule, you can actually remove individual beads. And so that's something you can do as well, where you slowly start removing those beads over a set amount of time, like let's say a month, right? And then each day you remove a little bit more of the beads. And then slowly you can get the patient down that way. Of course, the downside with that method is that you have to be very precise and individualistic to do that. It is an option. Number 5, I'll write number 5 here. So let's go to number 5, is to use a compound pharmacy. So basically, compound pharmacy will be able to make specialty dosage. Of course, that can be, it can be very expensive, like not covered by insurance. So that's why this tends to be an option that I use later down the line, not like something that I'll immediately go to. So that's number 5. Number 6 that you can do is you can use either Prozac or a benzo, depending on the patient's situation. So a lot of those side effects can be helped mitigated by using Prozac. Prozac has a very long half-life, fluoxetine, and so that can help cover some of that serotonin gap. It won't replace the norepinephrine gap, so that's why it's not a perfect solution, but it can cover some of that because it's got such a long half-life. Then, you know, you help you get the patient on a good therapeutic dose of Prozac, not necessarily even therapeutic, like even like 20 milligrams. So you get them on some Prozac, and then you start tapering the Effexor, and then you help them get off Prozac later. Or you can use the benzo to combat some of the withdrawal anxiety that they might experience. So yeah, those are all the methods I wanted to share with you to be able to taper Venlafaxine, Effexor. It's a good medication for the right person, so I don't want you to be scared that you can't use it. However, know that coming off of it can be difficult, so this is the framework that I want to walk you through to help you get off, or help the patient get off. And so if you want to learn real-world psychiatry like this, best place to do that is in our PMHNP Academy, where you can communicate with all our other students. I have psychopharm lessons on pretty much every medication diagnosis there is, and you can ask me questions too in our live Q&A. So definitely check that out. Otherwise, I'll see you in the next video.